Hi, welcome back to Healthcare Delivery Systems. I hope you had a great week, and this week we're going to be looking at long-term care and behavioral health. So this is the third week that we will be looking at healthcare settings, and this one will just look a little bit about long-term care and behavioral health and how it impacts healthcare delivery systems. One of your assignments this week focuses on a federal legislation that was called OBRA, and it's not in this slide, but I'm going to go into it a little bit so that will help you with your assignment. So welcome aboard. We're progressing quite nicely in the course. So the learning objectives for this week will be to describe different types of long-term care facilities with an emphasis on their function. We're not going to get into documentation requirements or standard sets or any of things like that in long-term care, because you're going to do that in your second year of the program in comparative records. So this is the basics of how their function is. We're also going to look at how long-term care services have evolved to meet a changing population, and then examine different kinds of facilities that are used for behavioral health services. Learning objectives are a variety here that you can just look over. So one of the first ones is school-based health centers. This isn't as familiar in our demographic area, but it says children can and should receive physical and behavioral health care in schools. We do have laws in our state that says you have to provide the services. So it can be nurses, social workers, and other providers. Treatment of any minor in a setting such as that does require consent. And the healthcare may be periodic, off-center, or a health service serving more than one. Usually what we're familiar with is the school nurse function. The aging population. Okay, why is long-term care important? If you look at this grid, you can see by the year 2030, the age of the average population in here. It's getting older, and it's getting older, but what does that mean? What it means is there's going to be more demand for healthcare services with an aging population. The aging population uses more services. The aging population, since they use more services, it also costs more money. So it is going to have a big impact on Medicare and other services such as that. One of the questions, and one of the key questions, who is going to be the healthcare workforce that's going to provide services for this aging group? And that is a primary concern, not only cost, but who's going to be there to do it. Every increase in technology increases cost of service. The group that's aging now, and I hate to say it, I'm at the end of the baby boomers, so I'm going to be there one day. Our population has gotten so used to technology and things that can improve our quality of life, the demand on these services are going to increase. Back in the 1950s and 60s, if your knee went bad, your knee went bad. There weren't replacement knees that you could do. If your hip went bad, hip surgery was major. Cataract surgery, even in the late 1960s and the 1970s, if you had cataract surgery, you spent 5 days in a hospital bed lying flat on your back. Today, cataract surgery is done as an outpatient. So you can see how technology has improved our quality of life, but it's also improved our aging. So higher age, more demand. One of the terms that they talk about in long-term care is ADLs. And ADLs means activity of daily living. So to ADLs mean, can a person bathe themselves? Can they dress themselves? Can they feed themselves? Can they transfer themselves? Can they walk? Can they use the toilet functions? One of the things with ADLs, that measures whether or not a person needs nursing care services in a place such as a nursing home. So when a person enters a nursing home, they will get an assessment, and part of that assessment will be what is their capability for their activity of daily living. Long-term care facilities and services, this chart here gives you an example of some of the different kinds. For example, if you go to a nursing home, you need help with ADLs, you need help with other services, you need help with care, very high cost. Community-based services, on the other hand, they need help with ADLs, they need help with services, but maybe it's not so much as care. Maybe they need someone who comes in and helps them shower 3 times a week, or maybe helps them cook a meal, that kind of thing. That cost is low to medium. As our population has aged, the demand for these other types of services at a lower cost will continue to increase. The issue is finding those services and finding people to deliver those services. Home health care. So what is home health care? That's assistance with a person's ADLs and chores inside the home. It can be done by family, friends, volunteers, maybe community, maybe skilled nursing of some medical issues. They might be at home and have skilled care such as a PICC line for nutrition that needs to be monitored. Sometimes home health care is paid for by Medicare, other times not. A home health care agency is another option. That's a professional organization that provides service, may be reimbursed by Medicare, and home health agencies also include hospice care or that end-of-life care. Board and group homes or group homes, that's a group living arrangement for people who need help with ADLs, but they can't live alone. So the residents may have physical or mental disabilities, some kind of impairment, substance abuse. They might be elderly, but not always. They provide meals, but medical care is not provided. Services, quality, and fees vary widely, and it can be paid in part by Medicare, Medicaid, assistance, and private insurance. So the most familiar kind of homes that you will see in our area for board and care is something similar to what used to be called TASC in my community. So you would have a home, maybe 4 or 5 bedrooms, and you would have a group of people who could not live alone, maybe need a little help with ADLs, but they just need someone there all the time. But they don't need medical care. They just need that assistance with their living. Assisted living, a person has their own room or apartment, usually in a large complex. They do get assistance with their ADLs. They do get 24-hour supervision, but usually the dining is a group. They provide social life, housekeeping, laundry. Some medical services may be on site, not a lot, but the service plan for each resident evolves over time. Now notice the key word there, resident. When you get into long-term care, they are called residents, not patients. It's a different name. To be an assisted living center, you do need to be licensed. Usually you get billed monthly and you get billed for extra services. If you have insurance, it may cover it. Highly unlikely, but Medicare does not pay for assisted living. Usually assisted living is that point when a person just can't live at home. They don't need a nursing home, but they need increased supervision. Continuing care retirement communities, those are different kind of needs, other types of housing, other types of agencies and organizations. Usually a nursing home is on site. It could be associated with assisted living, or they may have a separate home and apartment for independent living. So for example, this one nursing home in a community that I know of, they have their nursing home. They don't have assisted living, but they do have separate apartments close to their facility so that persons can be monitored for care or services that they need, but they're still living independently. Nursing homes. Nursing homes, just so you know, is one of the most regulated industries in the United States today. Highly, highly regulated. Nursing homes are inspected every year, and they cannot go over 15 months without some kind of inspection by the state. A nursing home cares for people who can't live in their home anymore or community, and it could be temporary or long-term. Some people go to nursing homes for rehab or rehabilitation, and then they can go home. People in nursing homes can have different kinds of conditions. It could be medical, it could be mental, or they could have physical limitations. Facilities have to help with ADLs. They need help with at least 3 ADLs to go into a nursing home, and they get nursing care. Nursing homes, they try to be home-like. Some are more hospital-like. The services there that you can see. Now, what I want to say about nursing homes, in the late 80s, about 1989, 1990, there was a federal legislation called OBRA, And what OBRA required was new regulations for nursing home. But basically what OBRA said, your responsibility is to get that resident to the highest level of functioning care that they can be in. That was a total mind shift for long-term care. So in your homework for this week, I have an assignment for OBRA that lists the regulations that went in. Now, I was working in healthcare about that time, and I remember when OBRA was impacted and everybody acted like the sky is falling. But today, all of those standards that you see there have become so routine, people never knew what it was like before. Other options for long-term care and older adults are in there. For example, the subsidized housing. You'll see that in many communities. That's usually financed by HUD through the federal government. They're usually apartments. They're small, but they're very compact and efficient. But they're for older adults, disabled adults, poor. Subsidized rent, so that way they have a place to stay. Billing is a percentage of monthly income. So, for example, my grandmother many years ago lived in subsidized housing. Her rent was $35 a month. Her Social Security at that time was about $450 a month, so it was based on her income. Hospice care, we talked about a little bit before. That's intended for patients with a terminal illness. Focus of hospice is they will not treat you to get you better. Their focus is palliative care. In other words, they know you're at the end of your life, or a person's at the end of their life. Their job is to provide comfort and make that person comfortable. So it could be pain medication, it's support for the family. It can be done in many different kinds of facilities, but they are those experts at that end of life. Legal and ethical issues in long-term care. Patients sometimes can't make their own decisions. So there has to be a series in place on who can. That we talk about in legal aspects of health information. But in long-term care under OBRA, the patient still has a right to participate in important decisions, and those are listed on your sheet there. So pay attention to that in your transcript, because when we get to legal, we will touch on it again, especially all of these different areas. Long-term hospitals. Remember, those are acute care hospitals that give care for more than 25 days. Patients usually in those hospitals have very complex medical problems. So they may have come from ICU. They have more than one medical condition that needs treatment, and they may need rehab. Medicare will cover the hospital stay if the hospital is Medicare certified. Then you get specialty hospitals and rehab care. That I mentioned 2 weeks ago, so that you can read over. Psychiatric hospitals have evolved quite a bit. Hospitalization for most psychiatric care is voluntary. It is very difficult for someone to admit another person to a hospital for psychiatric care without their consent. That consent, or to do it without their consent, usually has to be done by a court order. Psych hospitals have different kinds. They have open units, crisis stabilization units, midterm, juvenile wards, long-term. And some will specialize in certain illnesses and disease, such as substance abuse treatment. Day hospitals provide mental health treatment during the day. Patient then goes during home at night, and that's an alternative to outpatient care. Patients are adults or usually children, and it's usually managed. This provides respite for the families when a patient can go to a day hospital. Community mental health centers, that you can read over too. There's usually one there. Funding is always an issue in community mental health centers, may or may not be paid by insurance. Substance abuse treatment, they help patients overcome drug and alcohol abuse. You don't see these very often because funding or reimbursement for these services are so poor that many substance abuse treatment centers have closed and gone to an outpatient type facility. So unless it's private pay or reimbursed quite well by the state, they're not as common as they used to be. So that concludes Delivering Healthcare Summary Part 1. Sorry I went through it fast, so make sure you review the PowerPoints again and read your transcript for the course, and we will talk to you next week. Have a good weekend.